Welcome to the Coaching Revealed podcast series on health and wellness coaching. I'm one of your podcast hosts, Austin Matzel. In this episode, IOC Director of Education, Dr. Pamela Larde, interviews a panel on health equity, including Dr. Mullen, Dr. Endo, and Dr. Tracy Asamoah. As medical professionals in psychiatry, dermatology, and health equity, our panelists discuss the current state of health equity in the United States and the impact that coaches can have on the medical system, medical practitioners, and patients. This episode of Coaching Revealed explores how coaching can support patients, practitioners, and leaders in healthcare to meet the diverse needs of a growing and aging global population. The panelists discuss how to show up for others and work towards overcoming existing inequities, while ensuring new technologies don't exacerbate the disparity. Through their professional and lived experiences, our panelists and facilitator discuss what coaches are able to do by setting forth with intention and leadership. And together, we can build health equity into our world. Thank you for tuning in to Coaching Revealed. Let's get started.
All right. Welcome, everyone. This is Dr. Pamela Larde, Director of Education for the Institute of Coaching, and you are joining us for this episode of Coaching Revealed. And on this episode, we are going to be talking about health equity and the intersection of coaching and where that might fit in and what it is that the role of coaching, how this is relevant to the field of coaching. So I have three amazing guests who are going to be joining me today. And before I introduce them, I just want to share why this is such an important topic and why it's relevant to coaching, because there are a lot of different entities that can play a role in health equity. And sometimes it may not feel as obvious in terms of why coaching might be a part of the larger puzzle in terms of how we can enhance health equity. And we are going to be just considering how systemic inequalities impact health outcomes and really looking at the role that coaching within the medical field can play in addressing these challenges. So really, it's important because understanding these disparities can help coaches work to develop empathetic, informed approaches that inform clients, whether their clients are medical professionals, whether their clients are faculty members who teach in the medical field, members of different communities of people who may be experiencing those disparities directly. So let me introduce my three esteemed guests. In no particular order, I first would like to introduce Dr. Tracy Asamoah. Dr. Asamoah is a leadership coach trainer, child and adolescent psychiatrist, and a writer based in Austin, Texas. As a coach, she specializes in partnering with new and emerging leaders in academic medicine, healthcare organizations, and higher education institutions. Her diverse experiences uniquely prepared her to understand the complexities of physician leadership and career transitions. So welcome, Dr. Asamoah.
Thank you.
Our second guest is Dr. Endo. Dr. Endo is an associate professor of dermatology at the University of Wisconsin and attending physician at the William S. Middleton Memorial Veterans Hospital in Madison, Wisconsin. In addition to being a clinician educator, Dr. Endo received certified professional coach and life transitions training. He melds his passions for medical education and faculty development with coaching. And last but not least, Dr. Mullen. Dr. Mullen is the Associate Dean for Health Equity at Dell Medical School, as well as an associate professor in the school's Population Health and Internal Medicine departments. She also serves as the Director of Health Equity for Ascension Seton to help meet health equity goals across its system. Additionally, Dr. Mullen is a member of the Medical Executive Board at Central Health, where she is the Director of Health Equity and Quality. She is an internist, epidemiologist, public health physician leader, and the former Principal Deputy Assistant Secretary for Health in the U.S. Department of Health and Human Services. This first question is sort of around your particular field. Could you share your vision of what health equity looks like in your field and how coaching can play a role in achieving it. And for this question, we'll start with Jewel.
So I live with a very fundamental notion that all people have the right to be as healthy as possible, no matter who they are, no matter where they are, no matter where they come from. And so that short description of what health equity is takes us to a place that a lot of people now endorse. They talk about health equity. They say they believe in it. The reality is, though, achieving it takes action and commitment. It takes moving people to give up things without thinking that somebody's going to lose. And it takes the willingness to change the systems that have kept everyone from having the chance to be as healthy as possible. So I tell people I have health equity in my title. And I sometimes not really joke anymore that if you do, it's almost as if you're wearing a scarlet E, because that equity word has come to be so polarizing. And that's where in healthcare and in leadership, what I say is leading people to create measurable improvements for all people and narrow disparities is a serious leadership challenge. And when you wear a scarlet E, you minimally can benefit from a coach and somebody who helps you maintain your resilience.
Yeah. I'm going to speak from the perspective as a coach, but I will be mostly thinking about it in the lens of a psychiatrist and practicing as a psychiatrist. So as a coach, I'm going to give my idealized vision, building off of what Jewel was talking about, because I think we're at a really unique time in healthcare where we could potentially make the commitment to devote resources to places that truly benefit all. And it's a unique time. And I've been hearing this even in the last couple of weeks, where there is now this trend to look at the personalization of healthcare. How can we, at a cellular and microscopic level, understand individuals and how to best design treatment strategies and support strategies and prevention strategies that meet their individual needs, which is great, right? Because we're now saying that differences do matter. How we understand how disease presents in people and how people receive the things that are going to best help them either prevent or manage the diseases that they have. But what that means is we have to be willing, as Jewel said, to devote resources to everyone according to what they need. This isn't a zero-sum game. You're not going to lose something just because someone else got something that they needed. And in a given moment in time, that might look like it's balanced differently. In the dream world, resources would be allocated in such a way that honors and recognizes differences because they do exist. And the endeavor is to allow people access to what they need to, regardless of what community they come from. And I say that in psychiatry because in very, very basic ways, understanding how mental illness presents in different communities and then having access to resources in those communities is not meeting the needs of the people who really need those. As a coach, supporting leaders is having them understand within the context of who they are and where they work, how can they best meet the needs of the people that they serve.
I really appreciate that, especially this idea of looking at individual and maybe not down to the nitty gritty, each person sort of deal, but accommodating needs according to what the need particularly is. I have noticed that a movement in dentistry, in physical therapy, there are these revolutionary entities that are saying, look, we're going to operate independently of the larger system. And so you could be driving down the street and see this individual dental place that has their own plans, has their own payment systems, offers their own unique services that can be tailored to what that community needs. And so that's a movement I love. I don't know how it's doing, but I think it's a phenomenal idea. And so that when you were talking, it reminded me of what I'm starting to see there. So I'm going to jump to Justin. What are your thoughts on this, Justin, as it pertains to your field?
I think some of what I'll speak to is not just specifically to dermatology, but probably applies to all aspects. And I certainly 100% agree with everything that our other panelists said. I guess one thing that really resonates with me is that there's not going to be a one size fits all, that we have to meet in coaching. We always talk about in coaching school, meet the client where they're at, meet the patient where they're at. And equal is not always going to be the same for everybody. In fact, that's what inequity is about. It's not the same as things being unequal. It's about, you have to meet the client where they're at. And that's going to look different for everybody. I think that's really key. And to embrace that and not feel like, well, that's unfair, but that actually does create fairness and equity. There's inequities within dermatology from the lens of my practice. For instance, there's one of the fastest growing population segments are older adults, as well as non-white people. And the training that we've given to our physicians has not necessarily been inclusive of that. And that there's opportunities, for instance, for us to better train and equip healthcare professionals within dermatology to better understand some of the nuances, like Tracy was saying earlier. Like, how does inflammatory skin disease look in skin of color? Not the same. And if you didn't train in a place that doesn't see a lot of skin of color or doesn't really go out of the way to train you, how are you going to recognize that? There's lots of nuances to the question of inequity. Or another example is, what about fair access? Healthcare access, I agree, is a right that everybody should be have access to. But what about participation in clinical trials, for instance? There's a lot of inequities there where older adults historically have been excluded. Perhaps we have been researching questions that don't apply to older adults or to people with skin of color. For instance, there's a huge dearth of evidence about best practices for caring for certain types of skin conditions that affect predominantly people of skin of color. So there's lots of different inequities that are out there. And I think the other thing that struck me was how there's kind of this us versus them mentality. And I think that's perhaps where coaching could have a unique angle. How is it that we break that us versus them mentality? Is it really about us versus them, or is it about all of us? And I would argue it's probably about all of us, because if we help everybody and try to dispel some of these inequities, we can make a lot of movement there. And I think coaching also brings to the problem here, the challenge of how do we create action? How do we create creativity? How do we view things in a different way? How do we address accountability? And that's where I think coaching could be potentially part of that. But to be very clear, coaching is not a panacea. Like, there has to be reconciliation of people's past traumas, of inequities, of acknowledging the past and to allow for healing. And of course, that's outside the purview of what we as coaches do. But we have to acknowledge that coaching can certainly be part of this, but it's certainly not going to be the fix for everything.
I would love to hear you and anybody on the panel chime in on this us versus them idea. And
well, Justin certainly made me sit up even straighter with those comments. Because I talk with people a fair amount and observe a few things. The individuals most passionate about and doing the work in health equity tend to come from groups that are underrepresented and less empowered in their organizations. I've talked to some colleagues in academia who say they would not take those jobs or DEI jobs because they call them and I have air quotes for people, ghettoized positions. So that's an issue. But when we talk about what it means to support the individuals who do that work, it also reminds me about how often I talk about psychological and emotional safety with people and the importance of having the emotional safety themselves, and what it's like when people trying to advance health equity are not in psychologically safe spaces. In the discussions with people, trying to understand what it is about their experience, whether or not it represents some kind of trauma that makes them want to do that work. Because sometimes people choose a path. Like, people say, you do health equity work. And I say, I do leadership. I'm a doctor. And yes, I care about health equity. But sometimes people can be aided to go down a path where it's going to be even harder for them to achieve what they most care about.
Yes, and I think your lens is really important here too. So I think it's great that we have 3 medical professionals, 2 of which who are coaches, one of which who has worked with coaches. So yes. Anything else to add before I move on?
If I may, I'll add one other thought that came up after these really insightful comments. One is like looking forward to the future in healthcare and coaching. So we have this huge growing field of artificial intelligence. What does this mean? What could it do? But more importantly, I worry, and I'm hopeful, but I also worry, is this going to further advance inequities in healthcare? Is it going to further advance inequities in people who are trying to do the work, as Jewel outlined there? How is it that we can make sure that further advances in technology and resource allocation, all the things we've talked about so far, are being made in a way that's going to help everybody and not disproportionately help people who are already advantaged? Because I feel like some people are quick to assume that technology or advances are going to automatically trickle down and benefit everybody, when that might not be the case unless we're really intentional about it.
Ready to advance your coaching practice? Join the Institute of Coaching and tap into the world's leading resource for coaching science and professional development. With over 4,000 members across 130 countries, the IOC offers invaluable networking opportunities with an elite global coaching community and innovative learning to broaden your knowledge and keep you at the forefront of coaching best practices. Engage in cutting-edge learning events with world-renowned coaching scholars, from webinars and seminars to discussion groups, research projects, and more. Try any membership free for 30 days. Use promo code IOC Podcast and visit instituteofcoaching.org/join to get started.
It's such a hot topic with this AI, and it made me think how things often happen that, it's the new shiny thing and then we just run with it and we're not really slowing down enough. Although interesting, it sounds like there are folks in the tech industry that are even recognizing like, wait, hey, maybe we need to kind of be a little bit more thoughtful about how this is all going to play out. But I think especially in healthcare, I agree with Justin, there is the potential for people who are most vulnerable to issues around equity to really be left behind as things move forward. And that I think those who are leaders in healthcare, everybody in healthcare who delivers care, need to take ownership for being aware about what that might look like, both kind of globally, but in your day-to-day practice. So I'm hoping that as we start to use these technologies and integrate them, there are going to be people who run away with them because they're money makers and they're, they allow for growth in a way that has nothing to do with being human and patient-centered. But us who actually see people and take care of humans in healthcare, hopefully we can recognize what the implications are and really take ownership in how that looks for the people that we care of.
I think it's interesting considering, the three of you representing very distinct areas in medicine, from psychiatry, dermatology, internal medicine, how, curious to know what we're talking about disparities, but what do these disparities actually look like? Boots on the ground. We're working face to face with patients. I know Justin pointed out some in dermatology. What do these disparities actually look like in real life?
Yeah. In psychiatry, unfortunately, it's been a really, really unfortunate, difficult history of how mental illness has looked in any sort of diverse groups. But some of the problems that I continue to see, even as I was practicing clinically, and this was up until 2 years ago that I was seeing patients, was dealing with folks who were misdiagnosed. And so if I was seeing a 12-year-old African-American male in my practice, chances are he had been diagnosed by somebody else with a disruptive behavior disorder, when maybe this kid had anxiety or ADHD. A young Black male in 6th grade, and he's causing problems in the classroom, and he must be a behavior problem. Or if I got so few, no matter what city or state I practiced in, so few African-American males who came and saw me. But when I did see them, they had often been diagnosed with a substance use disorder or schizophrenia or something that, again, African-Americans were more likely to be diagnosed with, given the same symptoms compared to their non-white counterparts. And maybe this is a person who had depression or bipolar disorder or anxiety or PTSD. And so misdiagnosis is a huge issue. There's also, because of misdiagnosis and also because of a misunderstanding of how to create treatment in different populations, issues with over-medication, with inappropriate medications, with medication instead of less invasive treatment approaches being used, such as therapy or support networks. There's a lack of resources of mental health services in the communities that need them most. And so in urban communities, in cities that are primarily underrepresented communities, there aren't resources. So even if someone wants help, there's nowhere to get it. And if someone, and I trained in LA, even if they were just in a neighboring community, that might be an hour away of a community that looks very different from where I was training. We can't expect them to come all the way to where the services are to get their needs met. They needed to be embedded in the community and represent what their communities look like. And then just because of the historical medical practices in the African American community, there's a lot of mistrust. There's a lot of shame. There's a lot of resistance to getting help and asking for help. And this is, I speak primarily with the African American community because I've done so much work in that community, but this is in communities of immigrants. This is sometimes in women. This is in the LGBTQ community. These are any communities that don't look like, as Justin was saying, those communities that were studied for deciding diagnosis and directing treatments 50 years ago.
Well, and it's interesting because it's not always even, you're speaking to some of the communities that struggle the most and are facing the most dire circumstances. When we consider people who come from a place of privilege, like myself, in many cases, the lack of knowledge about, just being informed properly about some things creates an inequity in itself. As I mentioned, I can relate to, my son and the teachers constantly saying that, he's disruptive. And I didn't even know. And I think years later, cleaning out his closet, and he had a notebook in his closet from maybe when he was in third grade, and it was called My Angry Notebook. And the teacher wrote a note in there saying, this will help you with your anger issues. And as far as I knew at home, this kid did not have anger issues. But the fact that this was his label at school and nobody informed me, my lack of being informed created inequity. Compound that on top of having economic issues and being an immigrant, and it's just very complex.
So I think you both have touched on the recognition that we can't look at just the medical factors or the social factors in isolation. For as much as people talk about social determinants of health, it's just the convergence of either a community or group's experiences or an individual's experiences that might weight which factors have the greatest influence on their health and their ability to be healthy. And so as Tracy has, talked really elegantly about what she sees from a behavioral health perspective, I probably can come up with maybe a long one sentence about people who are under-resourced, people who are of racial and ethnic minority groups, as we know, experience a higher burden and lots of disparities in chronic disease, heart disease, burden, cancer, diabetes, etc. Even though life expectancy gaps for some are narrowing, not for all. And because I care a lot about healthy aging, I need to add that we still do not sufficiently recognize the impact of ageism and a focus on age as a medical issue as opposed to just another phase of life. And that also keeps us from really appreciating some of the mental illness and depression that older adults suffer when we talk about suicide rates in younger people. It's not all social determinants of health. We're not doomed. We are not ill-fated to provide good medical care because of somebody's social conditions. We have to have the will to provide high quality care. And we have more than 2 decades worth of national data that show that for a lot of chronic medical conditions, the disparities in treatment and outcomes have not narrowed in spite of ensuring more people and having even better evidence about what works. I think people have talked so much over the past decade about maternal morbidity and mortality. And that being another like very strong example of how your social class only is a predictor of poor outcomes if you realize that the risk might be being a Black woman of higher social class rather than of a lower socioeconomic status.
From what I've heard, it's because there is even more, I guess, silencing of Black women who goes into to receive medical services that knows her stuff and that asks the questions and that speaks up, and that is one of the reasons why she's at higher risk. But is that?
I can't say that anybody knows for sure. Okay. I think that issue of wanting to attribute a lot of the poor outcome to being underinsured or less healthy is debunked by the data that show that it's not just about your income or your lifestyle, which has made people continue to push on how inequitable and non-personalized and non-evidence-based listening to and then responding to women's symptoms and recognizing the signs that they might be headed towards an adverse outcome, how that's not happening. I shy away from just talking about implicit bias because this is just Jewel Mullen's pet peeve, that it gives people too much of an out, that if we're actually giving everyone the standard of care that our bundles and guidelines and professional societies say everyone should have, and then going the extra mile to recognize that the person before you is higher risk, maybe some of these outcomes won't be as bad. CDC and others have reported that as much as 75% of preventable maternal mortality is related to preventable medical conditions.
Yeah, I was going to reach out to Justin. And before I do that, I just wanted, you mentioned the social determinants of health. And so for those who aren't familiar with that, the CDC identified 5 key areas that includes education, access, and quality, healthcare and quality, neighborhood and the built environment, social and community context, and economic stability. With those intact, ideally we are in good condition. And based on what Jewel said, yeah, but not necessarily. So go ahead, Justin. I would just love to hear your thoughts.
Yeah, there's a lot to unpack. I think
I saw your wheels turning.
Yeah, I guess I don't think I have anything more eloquent to add to what Jewel already said. But I guess as we were talking about these things, what does healthcare inequity look like in the trenches day to day, seeing patients? Maybe I'll speak to that if that's okay. A couple things came to mind. The first thing that came to mind was during COVID, there was I thought, a wonderful opportunity for us to try to innovate. How is it that we can try to flatten these healthcare inequities using telemedicine, which is basically the remote care of patients through video or telephone, to try to break down some of these barriers? In Wisconsin, in Madison, Wisconsin, the land of beer and cheese. We're in the city in Madison, but we have a large part of the state of Wisconsin, as well as northern parts of Illinois. We have a large catchment area, and there was a lot of people in rural areas who already had difficulties coming in. And we thought, well, maybe this is a new way that we could try to leverage technology. And that was partially successful. But sometimes there's unanticipated things that come up. Like, for instance, we found that certain patients didn't have access to high-speed internet to be able to have that video call that we were supposed to use on this patient safety and confidentiality compliant platform, and that there were unfortunate stumbling blocks that we encountered. But I also want to highlight that, of course, people who come from certain marginalized groups who self-identify perhaps as Black or Native or definitely have historical inequities, but also rural patient populations are a huge area of significant need as well. So I want to emphasize that there's all kinds of different health inequities that are out there. A really just jaw-dropping moment that I had in clinic not that long ago, where I had, so at the university clinic, we get a lot of referrals from other dermatologists and other healthcare care providers outside the area. And I had an African-American woman come in to me to see me for a second opinion about her scalp condition. And I had a look, got my history, examined her carefully. And before I even had a chance to really talk a little bit more about what I thought was going on, she said, Dr. Endo, you are the only doctor who took the time to actually examine me and to listen to me. and take the time, like you actually cared about what was going on. And you actually seem to know what is going on and understand what this condition is that I have, that I feel like I've gotten kind of the runaround about. And I was like, wow, that, thank you for saying that. But also, wow, like, this is tragic and terrible that a patient is telling this to me, that they felt like they were not getting the healthcare services that were the right and that they deserved. And so, of course, I gave her my recommendations. And I was working with a medical student at the time. I says, this is a really great teaching moment for all of us about how we have a lot of work to do. And it's not going to be just one thing. It's not going to just be educating more. It's going to be a lot of things. There's going to be a lot of heavy lifting, but to be open to patients. And again, that's where kind of bringing it back to coaching is like, how is it that we can hear other people's, where they're coming from, and to understand their needs, and just to give them the space and the psychological safety to express their concerns and to really hear them out. But also, it was a real huge wake up call to me, like, wow, and I told my medical student, we all need to, it's not like just people who come from marginalized populations are the ones that are responsible for making it better. We all need to do this together, right? That was one of many teaching points that I had from that encounter.
And it's funny when somebody gives you that compliment, like, wow, you listened to me. That's basic, right? I mean, that's not supposed to be so shocking. And yet it is. And yet that is something that people don't experience on a regular basis. Earlier, Jewel mentioned, just talking about implicit bias is, it's kind of exhausting. And sometimes it kind of seems like a loophole or a way out. What I'm really seeing in this era is a prevalence of conscious bias. So it's not even, implicit. It's not even, I don't know that I'm doing this. It's more of a willful bias that we're seeing happening. And I don't think that gets talked about enough, because implicit bias, we can talk about that all day long in the medical field, and how we don't realize some of the things we say to people are based on deeply seated biases. But how often do we see things that are actually quite intentional and quite willful?
That's, as Jewel said, that is not just another bunch of podcasts, but a whole series of podcasts. But, I'll bring it to coaching, because I think there's a really interesting way that coaching can start to support people around this. And when I start with most of my clients, we do a lot of discussion around their values. And, someone's values are their values. It's not my role as a coach to judge them or to help them determine what those are, but it is my job as I partner with them to help them understand what their values are and how their life professionally and personally align with their values, and how that's impacting how they live and how they work. And also what their vision is for who they see themselves as their idealized selves, right? And when I think about someone who holds, whether it's implicit or explicit or conscious bias, as we start digging around what their values are, how those perceptions are misaligning or aligning those values, then some of that stuff might start to emerge. And then they can really look at it from a place that doesn't force them to feel defensive and double down on whatever that bias is. Because I imagine if everybody had the resources, opportunity, the knowledge, or whatever it took to work with a coach and to really dig down on what these biases are for them and what their actual values and vision and perception of themselves are, there would be so much misalignment that there would be a lot of places to make some really important changes. Wouldn't be true for everyone. There's some people who really believe what they believe. It's, hardwired. It's from early experiences, and it would take a lot more to shift that. But I also think that if people really did truly have an opportunity to stop and think about what they may believe about someone else and what their values truly are, there would be shifting there.
Based on what you just said and the vision that you offer, I think it's really important to think about how we as practitioners, and then how as coaches, to influence people to change the culture of medicine. Because there's something about the way people behave that is manifest in the form of implicit or conscious bias, but our culture, even if someone is I'll say perpetrator is unconscious, there's probably somebody in the room who's conscious and is wondering, what just happened here? I didn't like the way that sounded. Could that person be one of those kind of people? But the culture is not one that will then have someone feel as if they can speak up about it, especially in a learning hierarchy or in a practice hierarchy. Who could appreciate, for example, the modeling that Justin maybe didn't even realize he was providing his learners by just paying attention to a patient? But what learner might have felt comfortable saying to one of Justin's colleagues who maybe just said, oh yeah, another person with such and such and such, they need to do their hair differently or whatever. The kinds of things I think somebody might say, or I've heard say, that doesn't happen. And then the group doesn't get to explore. And the so-called, in medical school, what they call the hidden curriculum, just instead becomes the perpetuation of a culture. And that labeling is damaging, because some of the other bias occurs when a patient is described as difficult because they demonstrate that they know they have agency.
But I do want to get to one of the questions that I had for Dr. Jewel Mullen, which is, you've spearheaded health equity initiatives at multiple institutions. And I would love if you can share, if at all, any successful initiative that you had and what might have made that effective.
Since I consider health equity work the cathedral building work that you may never see the end, it's just perpetual. I like to measure my impact by whether or not something is still moving forward well after I'm gone, even if we're not there yet. So in thinking about this question, I said, okay, I have to, how far back do I need to go? So some of the work I did when I was the Commissioner of Public Health in Connecticut. And so I'm going back a little over a decade now, where I had an excellent team. I think if you're a wise leader, you know who your experts are, so you support them, right? And so I had an excellent team that was doing a lot of work in health disparities, and I think their office was called Multicultural Health, and it was programmatic. And the staff was trained to do epidemiology, statistics, a lot of program transformation, and they came to me and said, we really want to be the Office of Health Equity, Evaluation, Research, and Policy, because we want difference. So we wrote legislation to take the money that was funding multicultural health and to create an office that was going to be very data-driven, and then to take some staff that had been embedded and not empowered and say, you want it, I support you, you lead it, I have your back. When you decide to put a system like that in place, you're building accountability for your state agency, but you're using state data to build accountability for the state, to actually say, are we moving the needle in a variety of areas? And then this office can become the place that can address many issues. The legislation was passed. We created the Office of Health Equity Research and Evaluation. That meant that people who were being underutilized for all of the doctorates and expertise they had actually were elevated to even do more work nationally. I peaked because I wanted to use this example, but I figured I should see whether or not the office still exists. So I looked last night. And I mean, they've just taken off, and I knew they had, but to me, that's so much more about supporting other people to spread the work and spread the influence.
I love that. Effective longevity, longevity by itself doesn't, necessarily mean a lot, but the fact that it's still going is really important. And then, so in the spirit of solutions and what kinds of things are happening, I wanted to turn to Justin and ask, Justin, can you elaborate on the coaching initiatives that you're using for faculty development?
Yeah, happy to. So at the University of Wisconsin, we really don't currently have any formal coaching services internally. But what's interesting, and a lot of my time is actually spent trying to educate physicians and leaders within the organization what coaching even is, because a lot of people still misconstrue coaching as like therapy or remediation, or I guess in the context of skill development, like, improving your communication skills or being more efficient at doing your surgeries or whatever. But obviously we know that coaching is well beyond that. But a lot of what I do actually is where a lot of the demand seems to be, at least at my institution, is in having people learn about the coaching skill set and how that can apply to more familiar roles, i.e. mentoring residents or other learners, or mentoring junior faculty. And so a lot of what we do with my collaborators and I is really focusing on taking a subset of those coaching skills, like really deep listening, removing judgment, which of course takes practice, right? It's easier said than done. And learning some of the core principles of coaching. We're not currently training people to be coaches, which is obviously, that would be a wonderful dream someday. But right now it's just trying to find quick wins in some ways to try to empower people to be like Jewel. And again, bringing back that whole point about creating psychological safety and space for people, particularly some people who we work with who do come from historically marginalized groups who feel like they're silenced or not heard or have to put on the game face and can't really be their whole authentic professional self. I think that I would personally argue, perhaps somewhat blasphemously, that we can share these coaching tools with other people who are doing great work, and that can kind of plant the seed for changing the culture of medicine, which I think Jewel is 100% right. Coaching is one piece of that, and you're not going to change it overnight. It's going to be an ongoing cathedral being built, as you said. And by just kind of my contribution, I feel like, along with other people who are like-minded at my institution and across the nation, is how is it that we can help people understand what coaching is and what it isn't, and providing people the skills and to try to make it as accessible as possible. There are some people who actually have reached out to me to ask about my coaching training journey and, where I started out with my own coaching, receiving coaching, and then going on to be trained as a coach. And that's always a lot of fun for me to be able to share that. But I feel like it all is coming back to how is it that we can take the coaching skill set, meet people where they're at, plant seeds, and it'll eventually grow as a legacy down the road, or a cathedral.
I love that. I mean, this is really embedding coaching, a coaching culture, coaching approaches into the work that we do, no matter what position that we're in. And I wanted to just kind of close out with one more question as it applies to your particular field. And I'll start with Tracy on this one. But from the standpoint of psychiatry, I'm curious to know what you might offer in terms of your own experience and wisdom to coaches that are either working within or outside of the field that can really kind of help address issues of equity?
Yeah, I mean, I think there are so many ways that coaches can support people within that realm. And I think there's a lot of different aspects. I think one really interesting place that coaching can be powerful, not just from the perspective of being a trained coach, because I'm like very similar to Justin. I think there is a coach approach to engaging in all sorts of relationships that can have so much value in how we listen, how we show up with curiosity, how we show up as partners to people, even with our patients and in the communities that we serve. We can come in as curious, helpful listeners who want to empower people to get what they need. But on the flip side, as coaches, we also often coach people who themselves need help with mental health issues, with psychological issues, it could just be with dealing with stress or burnout, and removing the stigma and creating a safe place to either support that person as a coach or help them find what they need to get the support that they need. Now, that means that the culture of healthcare and medicine needs to allow for this. And it does a horrible job at doing that. It doesn't make it feel safe for someone who is delivering healthcare as a healthcare professional, whether it be a nurse or a physician or even someone who's at the administrative level, to feel that it's okay to need help with their mental health and to have a safe confident way of getting that care without fear of retaliation or punishment or losing something, losing their license, losing their position, losing their reputation.
That stigma for leaders is real. You know, you're a CEO and you're discovering that you're having some real challenges, you know, and you and your coach may identify some of that. You may realize you need to get some more support. But then how do you address this in the workplace?
And how do we make space for it? I was coaching someone yesterday. She's a regional leader in nursing and doesn't feel safe enough to pay attention to her own well-being to say no to a meeting that she was initially not going to go to, that she didn't even feel that she actually was expected to participate in, but they just wanted her there because that's just what they expected. And so had to cancel plans to do something with her family because she didn't feel it was safe to say no, and I need to do this. And this is not an exception. This is the rule. And this has also contributed to her not feeling that she has the time or space to put her well-being first, which unfortunately directly impacts how she's able to show up in her job, in her personal life, how well she's able to do it. And not prioritizing that, not being able to allow people to thrive in what they do means they're not going to do what they do as well. I mean, the implications ripple throughout organizations. Just paying attention to these really basic needs that people need to have met.
Just really meeting people where they're at, meeting your clients where they're at, whether it's if you're a healthcare coach and you work with patients, or if you're a coach, leadership coach, transition coach, wellness coach that works with healthcare professionals, just meet clients where they're at, see what their needs are, hear them out, provide that space. Coaching can support people, even those who do suffer from mental health conditions. We as coaches are part of their board of directors, so to speak, right? In my opinion, I view coaches as part of the board of directors for people in all walks of life. And I think that acknowledging that there's multiple layers of complexity to the healthcare system, certainly to healthcare inequities that we've discussed, there's not going to be a one quick fix. And of course, we have coaches know that we're not there to fix people's problems. We're there to understand the person that we're speaking to and to provide the space and to help them try to come to some different perspectives or new solutions and insights so that they do feel more empowered and can actually act and not feel like they're just being driven into the ground.
And last but not least, Jewel, what words of wisdom might you leave us with today?
I want to reinforce everything that Tracy and Justin just concluded with and ask people to be perpetual learners as they coach people who are passionate about health equity. People come to you with a name and a title, and they can tell you their story. And if you hear that they're trying to advance health equity or justice, you might shortcut into your own understanding or thoughts about what that means. And we started this whole conversation with a little description of what health equity is. I think to really support people well in this space, continue to learn, to understand more about the realms that they're actually walking through every day, and you will be even more help to them.
I love that. I saw a LinkedIn post recently that said, with all of the challenges that we're facing with diversity, health equity, and just across the board, not specifically in this field, we're being challenged to learn new language or use new language that will be more acceptable, to those who are feeling threatened by any of this work. And I love the way that the person who posted it she said that we essentially are trying to teach people how to human better. And I just love that from head to toe and from inside out. Just love the idea of how do we human better? And I think that captures what we've said today and what we've talked about today. So I just want to thank you all so much for your time and your expertise today. I hope that for those of you who are listening, that you're able to kind of think of, how does this apply to the work that I do? And how can I integrate some of these concepts and learn more and continue to dig and continue to grow in these particular areas? Because it does impact all of us. At the end of the day, we are really wanting to learn how to human better. And if we can get that right, that's, I think, half the battle. So thank you all so much for joining us today. Wonderful discussion that needs to continue. I hope this isn't the last. And I look forward to all the feedback and that you listeners have. Thank you, and have an amazing rest of your day.
Thank you for listening to this episode of Coaching Revealed, brought to you by the Institute of Coaching. You can learn more about the Institute on our website at instituteofcoaching.org. You can stay up to date with new episodes of our podcast by liking and following Coaching Revealed. You can also find us on social media on LinkedIn, Instagram, and X with the handle Institute of Coaching. We also love hearing from our guests, so please reach out to us with thoughts you have on this episode and any questions you have about coaching. Until next time, this is Emily Tarani with Coaching Revealed.